Okay, so moving on from your active assessment of the hip into your passive assessment of the hip. Okay, so again, what's really important when we do this is how we look after the patient. So again, hand under the popliteal space, okay, in the popliteal fossa, and just try and slide their leg up, okay, because you don't want to be lifting any more than you have to be, and also we can start to engage flexion of the hip and see if it is painful for them. Okay, when we've got to about this position, we're going to need to engage the hip more, so we're going to need to bring the leg up. Your hand comes up and underneath the calf, your hand over the top of the knee, and this basically resting in the central line of your body. From here, we can bring flexion in. Again, we're looking for about 140 degrees of flexion of the hip. We're also assessing for quality of the movement. Does your patient have any pain? Is everything okay as we're doing this? Okay, and that's fine. Good. Okay, so a good range of flexion through there. Okay, then we can look at internal and external rotation. So external rotation, we'll look at first, keeping that femur at 90 degrees and keeping it straight up. So what we don't want to start doing is increasing or introducing adduction into the movement. Okay, so keeping it straight up through here. We're looking for about 60 degrees of external rotation. Okay, and again assessing for a range of movement and end feel, and if your patient has any pain. And then we're looking for about 35 degrees of internal rotation through here. Okay, good. We can then look at add and abduction. Now, when we look at add and abduction, we tend to do this as a combined movement. Okay, so when we look at adduction, we're going to leave some degree of flexion in the knee through here. Okay, we're going to take control of the patient's pelvis to hold the pelvis, and we're just going to try and adduct the leg in. Okay, so we're again looking for about 45 degrees of adduction through here, and then we can also allow the leg to drop out, contracting the contralateral pelvis over on this side, and we're probably going to be expected to see something like about 60 degrees of abduction through here. Okay, again thinking about the range of motion and the joint quality of movement. You can then stand at the bottom of the bench and support one leg and look at pure vector of movement. So we can look at sort of pure adduction through here and pure abduction from here. Obviously, think about where you stand when you do an abduction. Okay, so we want to be more at the side for abduction, but you need to be at the foot for adduction over here. Okay, we can then move on to some clinical tests, and so from clinical tests we could look at Faber-Patrick's, Scow test, Thomas test, and Stellenberg's. So if we look at Faber-Patrick's, I would normally do it on the side of the bench that I'm on. So I would normally bring this leg up and drop it out here. However, I think it's probably going to be easier for the camera to see it if I do it on the opposite side here. So if I do it on the opposite leg. So what we want to make sure we do is we're going to bring the leg up, okay, to flexion. We're going to bring the lateral malleoli and just place it just above the patella. So you don't want to place it on the patella, it needs to be just above the patella. Okay. You want to make sure you're supporting that knee all the way through and contacting the contralateral aspect of the ASIS, contralateral ASIS. Okay, and you want to allow that leg just to deck out and go as far as it can through here. What we're looking for is a smooth range of motion. We're looking to see if there's any pain, but also we're looking to see how far the leg will come down. So what's classically classed as normal would be just allow the leg to drop down, drop down, drop down. If you get the knee roughly in line with the femur on the other side. Okay, so that's relatively normal through there, and then we can bring it back up. Okay. Another test we can do is the Scow test. So with the Scow test, what we're looking for is if there is any cam and pincer deformity, or if there is any labral tears or anything like that, or trauma to the joint. Okay, so with the Scow test, we're going to start almost in the Faber-Patrick position. And what this is going to do is it's going to open up the front of the joint, okay? So then what we're going to do is we're going to bring the leg up, we're going to adduct, we're going to externally rotate the leg and bring it down. Okay, so this is your movement. While you're doing that, you're going to apply overpressure, just a little bit through the knee, okay, so through the line of the femur. And you're also going to be assessing for how the joint feels as you're moving around. Okay, and what we're doing there is we're rolling the head of the femur around the anterior aspect of the labrum. So as we roll it, so this is the head of the femur, and this is the labrum, or the anterior acetabulum, can't think of the word. Okay, we're going to roll it around the anterior aspect of the acetabulum. So if there's pain when we're doing this version of the scar test, then that is going to be suggested that there is a problem with the anterior aspect. Okay. If we want to go into the posterior part of the acetabulum, okay, we're going to start with the knee, we're going to bring it up, we're going to adduct, and we are going to internally rotate. Okay, and then from there we're going to apply a little bit of overpressure, and we're going to bring the knee around into adduction, external rotation. Okay, through here, and then down slightly through the side. Okay, and then what we're going to be doing here is assessing the posterior aspect of the labrum. Okay, so we're going to bring the leg up, adduct, internal rotation, okay, reflection, overpressure through the knee, and just through here, and then back up and around. And again, what you're looking for is quality of range of motion, quality of range of motion in the femur, in the hip, and if that what it feels like as you're on around the joint, and also if there is any expression of pain. Okay, we could then look at Trendelenburg's and Thomas test. What I didn't do was extension, because that requires my patient to lie on the front. You can obviously do extension before you move on to any special tests. If I can get to lay onto your front for me, please. Okay. So when we're looking at extension, we can basically bend the knee, okay, and then we're going to lift up from the ankle and pop our hand underneath the knee joint. So we're actually holding on to the inferior aspect of the femur. Okay, going to support the pelvis over the top, so around the PSIS through here, and then gently with your body lift up the leg. You're just assessing extension through here. So about 20 to 30 degrees of extension would be classed as normal through here. Okay. While you've got your patient in this position, you could also assess trochanteric roll. So if you grab hold of the greater trochanter, then you can basically, you do it on the side that you're stood nearest, basically roll the trochanter through here, and we can just see how that movement works through there. Okay.